Hello friends, this is Dr. Rakesh Mittal, Senior Faculty in Surgery at Aakash PG. We'll be coming out with a series of lectures for the preparation of upcoming NEET exam. So the first in this series is surgical principles, surgical aspects in hernia, which is very important from your exam point of view. So we'll be talking about the major types of external hernias: inguinal, then femoral, and then the ventral hernias, that includes epigastric, umbilical, paraumbilical and incisional hernia. So first is inguinal hernia. Quickly, just a review of the inguinal canal. All of you know that's the inguinal canal, an oblique canal in the lower part of anterior abdominal wall, bounded by a deep inguinal ring, which is an oval opening in the fascia transversalis, half inch above the midpoint of inguinal ligament, and the superficial inguinal ring, which is triangular in shape in external oblique aponeurosis, 1 centimeter above and lateral to the pubic tubercle. The spermatic cord passes through the inguinal canal. So there are two types of inguinal hernia, the direct and indirect. Indirect hernia enters along with the spermatic cord and comes out through the superficial ring, whereas direct hernia enters through the posterior wall directly into the inguinal canal through the Hasselbeck's triangle. Okay, now the surgical principles. There are three basic techniques: herniotomy, herniorrhaphy and hernioplasty. Herniotomy is otomy, as you know, anywhere it means opening and closing. So we open the sac, reduce the contents and ligate the sac at the neck of the hernial sac, and if there is extra redundant sac, we remove it. That is not necessary. This is most important: opening the sac if required, or reducing the sac completely along with the content. Herniorrhaphy is additional repair, right? Herniotomy alone is not sufficient, particularly in adults. We need to repair the defect. If we repair the defect using local tissues, muscles, fascias and others, so that is called herniorrhaphy. Hernioplasty, where we repair the defect using some external prosthetic material, and you know it's mesh. Right. Now, what is the significance of herniotomy alone? Very, very important question. It's a treatment of choice in children and infants for congenital inguinal hernia and also the congenital hydrocele, because the process, the pathology is same: persistent patent processus vaginalis. So we have to close it. So treatment of choice is herniotomy, also known as Meckel's flank operation. Why we do not do repair in children? Because the anterior abdominal wall is growing, it will grow with age, so the dimensions of inguinal canal will change. So any repair is not advocated at this stage, so only herniotomy is sufficient. Now the types of herniorrhaphy: repair using local tissues. The most important top four, in fact the first two are the most important: Bassinet, Scholdes, McVey and Little's repair. There are few others we'll be discussing. Bassinet, simple words: approximation of roof to the floor. Roof is the conjoint tendon formed by the transverse abdominis and internal oblique muscle fibers, and floor is inguinal. So approximation of roof to the floor, that closes the posterior wall defect. So that's a roof, the conjoint tendon, and that's inguinal ligament. So we are approximating these two layers, and in this you can see it has been closed, right? Inguinal ligament, and that covers the posterior wall defect. That's a Bassinet's repair. Scholdes is double breasting of fascia transversalis. Fascia transversalis is the important part of posterior wall of the inguinal canal. So double breasting, so that takes care of the posterior wall defect, which is important in direct hernia or large indirect hernia as well, and narrowing of the deep ring through which the indirect hernia comes, right? So both the aspects are taken care of it. So that's a deep ring which is narrowed, and as you can see, double breasting. Double breasting means we divide the fascia transversalis, or it's already open, and we cover one layer over the other layer. That's double breasting, that gives the additional strength to the posterior wall. So that's a Scholdes layer, one layer over the other layer, right? McVey, remember, very, very important, just one word: it's a Cooper's ligament repair. So Cooper's ligament is very critical part of the repair. So Cooper's ligament is, it's approximated to transverse abdominis and fascia transversalis. it not only closes the inguinal defects, it also takes care of femoral defects. So 2 points you need to remember. McVay, it's a Cooper ligament repair. Second, it also closes the femoral hernia or femoral defect. So that's a Cooper's ligament. So you can see this is being approximated to the transverse abdominis and internal oblique. So that's a Cooper's ligament. It's a relation to the femoral ring through which the femoral hernia enters. So when you approximate it, so that covers the not only the inguinal but also the femoral defect. Now the Little's repair is just the deep ring narrowing. So simple small hernia, the posterior wall is intact, we can use it but not much of use in current day practice, today's practice. So we just close the deep ring, that's Little's repair. So as you can see here, so deep ring is closed with some sutures. Now Tanner slide operation. Tanner slide is not a surgery by itself, it's not a repair, it's addition to the repair. Either we are doing Bassini's repair, we are approximating roof to the floor. So sometimes the tissues are tight, so when you are closing it, so it is very tense repair, right? So and tension is not good for healing. If you close it under a lot of tension, it might give a later in the future. So that's a cause of recurrence. To release the tension, we away from the repair site in the lower part of the rectus sheath, we give a relaxing incision. Let me show you the picture. So that's a repair of the inguinal canal we have done, right? And away from it in the lower part of the rectus sheath. So Bassini's repair has been done, but if you think it's under great amount of tension, we give a relaxing incision in the lower part of the rectus sheath. So tension on this repair goes down. So that's a Tanner slide operation to reduce the recurrence. Now Kuntz's operation is used only in very few selected cases, very old age, like 70 years, 75 years patient, lots of comorbid conditions. You cannot take a chance of recurrence. So the best way is completely close the inguinal canal, remove everything. Remove the spermatic cord, divide the spermatic cord, remove the testes. That's the only purpose of the inguinal canal, the passage. So when we remove the testes, so that passage purpose is gone. So ring is inguinal canal and the rings are permanently closed. So no question of recurrence at all. Hernia never recurs, and that's the use I have already explained to you. Now Desarda repair, you should know about it recently. Desarda is a type of herniorrhaphy. Local tissues are used. It's a creating a local mesh, a strip of external oblique aponeurosis, around 1 to 2 centimeter of external oblique aponeurosis strip is divided. It's isolated from the main muscle, but it's attached on the medial and the lateral end, and then it is sutured like Bassini's, sutured on one side to the conjoint, lower side to the inguinal ligament, like a mesh, right, or like a Bassini's repair. So that's how it takes care of the posterior wall defect. So that's a strip I am talking about, external oblique aponeurosis, that has been, but it's attached on both the ends with the muscle. Only the middle part is separated, and one side it is approximated to the conjoint tendon and one side to the inguinal ligament. So it covers the posterior wall defect. Okay, now the types of hernioplasty, right? The mesh repairs, the most important, most commonly used, and you can say highest success, least recurrence rate, Lichtenstein's tension-free mesh repair, where we just lay down open flat sheet of polypropylene, non-absorbable, a synthetic mesh is placed over the defect, over the fascia transversalis, and it has really low recurrence rate. That's how a mesh is placed over the posterior wall, encircling the spermatic cord. So it takes care of both the indirect defect as well as the posterior wall defect. Now other mesh type of mesh repair which was used in older times is Topaz preperitoneal mesh repair. It's technically difficult, but it's very good type of mesh repair, very important. Recurrence rate is again very low, and it also takes care of all the defects, inguinal, direct, indirect, the complete myopectoneal orifice, even the femoral defect is taken care of. And this is comparable to the TEP, which is a laparoscopic repair, that is total extraperitoneal repair. It's an open technique of doing TEP. This is also known as GPRVS, that is great prosthesis reinforcement of the visceral sac. And in this we place a large sheet of mesh either in the retromuscular or preperitoneal space, like in this picture you can see. So that's a rectus muscle. So between the peritoneum, that's a peritoneum, that's a rectus muscle. So retromuscular, that is behind the muscle, or preperitoneal, that is in front of the peritoneum. So that's the Stoppa's repair. Mesh plugs, very small defects in the posterior wall, you can just insert a mesh plug of mesh to close it, right? Proline hernia system, it's again a different kind of mesh, 2 layers with the connector. Let me show you the picture. So 2 layers and a connector in between, right? So 1 layer outside the fascia transversalis, connector through the defect, and 1 layer under the fascia. So it completely covers both from outside as well as inside the defect, right? So that's the advantage of the Proline hernia system. Now ideal mesh, this question again has been asked many a times. Ideal mesh is lightweight mesh, large pores, low in weight, because less fibrosis, less tension, less foreign body reaction, and lesser shrinkage. So that's the advantage of this ideal mesh. Now in cases of strangulated inguinal hernia, like obstructed or some vascular compromise of the hernial content is there, we always use fundus first technique, very important again. Now fundus first technique is, that's a hernial sac, that's a neck means defect through which hernia comes out, right? That's a fundus, that's a body, right? Normally we have to ligate the sac at the neck, we open the neck. As soon as you release the neck, what will happen? The contents will slip back into the peritoneal cavity. In this case, because we have to see the contents, because it can be gangrenous bowel and there will be toxic fluid inside this because of inflammation, obstruction, and gangrene. So that's why never cut the neck first, always open the fundus first. Once you open the fundus, you will have the entire content, take out drain all the toxic fluid. If the content is healthy, you can push it back. If the content is unhealthy, you have to resect the gangrenous part of the bowel. So drainage of the toxic fluid, inspection of the contents, viability, these are the 2 important advantages because of which we want to do a fundus first technique. So this is all about open repairs of inguinal hernia. Now the laparoscopic repairs. Open repairs, as we have seen, we put the mesh from outside. Laparoscopic repair, we put the mesh from inside. So posterior repairs. The 2 standard indications, bilateral inguinal hernia and recurrent inguinal hernia. Now all laparoscopic repairs are mesh repairs. So technically they are the types of hernioplasty, and the mesh is placed in the preperitoneal space. This is important. If you remember, we talked about Stoppa's. That's why I told you Stoppa's is a kind of laparoscopic repair similar to laparoscopic repair done by open technique. So mesh covers the entire myopectoral orifice. Same I told you for Stoppa's also. So the points are same. Only difference is there it was open, here it is laparoscopic. So completely covers the Hasselbeck's triangle that takes care of direct, covers the deep ring that takes care of indirect inguinal hernia, also covers the femoral ring, so that takes care of the femoral hernia. Okay, 2 types, TEP and TAPP. Remember, these are just the 2 different techniques. The end result is same. In both these, we have to place a mesh. In both these techniques, we place the mesh in preperitoneal space. So end result is same, only the route is different, right? So TEP, total extraperitoneal repair, TAPP is transabdominal preperitoneal repair. The difference you can see in the name itself. Total extraperitoneal, in this we remain outside the peritoneal cavity, we do not enter the peritoneal cavity. Wherein TAPP is transabdominal, we go through the peritoneal cavity. So only the route is different, the destination is same, right? Say this is the umbilicus, the point of entry for laparoscopic repairs, and that's the peritoneum, that's a rectus muscle. So that's a preperitoneal space where we have to place the mesh. So in TEP, we directly enter into this space and place the mesh, reduce the hernia and place the mesh. Whereas in TAPP, we first, the point of entry is same. We first enter the abdominal cavity, that is peritoneal cavity, and then we penetrate through the peritoneum. We cut the peritoneum and then we enter into the preperitoneal space and place the mesh here. So only the route is different, the end result is same. So that's another angle. So that's the umbilicus point of entry, that's the peritoneum. So in TEP we directly enter it, whereas in TAPP we first go into the peritoneal cavity, and that through the peritoneum we reach the preperitoneal space. Now the landmarks, anatomical landmarks in TEP, that is preperitoneal space, are very important, very frequently asked in your exams. So this is the nomenclature. First the median umbilical fold, this is the preperitoneal space, the view. Below you will have peritoneum, above you have the anterior abdominal wall, in between is the preperitoneal space. So median umbilical fold is found by urachus, then medial umbilical folds, they are found by the umbilical artery, and lateral umbilical fold are formed by the inferior epigastric vessels. So that's a deep ring, the entry for the indirect inguinal hernia, right? And these are the testicular vessels. This is the vas deferens, right? Now this is a picture showing you how the indirect hernia looks like inside. So that's a widened deep ring for the left inguinal hernia, testicular vessels and vas deferens. Now this is the most important slide, right? The orientation of the different parts, different defects. So that's the inferior epigastric artery vessels. So that's a defect for the direct hernia, that is the Hasselbeck's triangle. That's a deep ring, which is defect for the indirect hernia. That's a femoral ring, that is defect for femoral hernia. And this is triangle of doom and triangle of pain. I'll just explain them to you. Triangle of doom and triangle of pain. So this is direct hernia, that is Hasselbeck's triangle. This is the deep ring. Okay. So that's a triangle of doom. That's a triangle of pain. Okay. Now this is the mesh placed inside the preperitoneal space. So as you can see, so that's a deep ring. So it has been covered with the mesh. That's the direct hernia, the Hasselbeck's triangle, and that's the femoral ring. So all three defects are covered with the mesh. So this is the preperitoneal mesh placement in laparoscopic inguinal hernia repair. Now these are the anatomical landmarks. Each one of them is very frequently asked in your exam. Triangle of doom, pain, circle of death, also known as corona mortis, and trapezoid of disaster, right? So let me go back to this. So triangle of doom, this is for the right side. So you will have the vas deferens medially, gonadal vessels, or if it's male, testicular vessels laterally, and below is the peritoneum. So peritoneum, testicular vessels, vas deferens. This is triangle of doom. Why we call it triangle of doom? Because it's a triangle of danger. So never dissect, go deep into this triangle, because just behind in this triangle you will have the external iliac vessels, artery and vein, and you can injure, and the story ends here, right? Many of the cases you will lose the patient, a potential bleeding in a closed space, right? This is triangle of pain. This is iliopubic tract, testicular vessels. So between this is triangle of pain. Why we call it triangle of pain? Very easy, because lots of the nerves, the cutaneous nerves, are running into this space, and if you do a lot of dissection or use pins, tacks in this area, that can entangle or entrap the cutaneous nerve and can cause post-operative pain or neuralgia, right? So that's a diagrammatic representation of triangle of pain. So that's a deep ring. As you can see, the external artery and vein, and multiple nerves going through the triangle of pain. So most important is lateral femoral cutaneous nerve of the thigh, one of the most commonly injured nerves in laparoscopic inguinal hernia repairs. Even this question has been asked before. So that's the corona mortis, that is circle of death. So it's a vascular arcade you have to take care of. Now you should know the component arteries of circle of death. The common iliac with both the divisions, internal and external iliac, connected by obturator and aberrant obturator artery, and completed by inferior epigastric artery. So this is about inguinal hernia. Now next is femoral hernia. Now femoral hernia, this is anatomy, all of you know, the femoral canal, the artery, the vein, lateral to medial, the medial most compartment under in the femoral triangle under the femoral fascia, right? So the entry is deep ring, normally there is lymph nodes inside, and the exit is the saphenous opening. So abdominal contents enter through the femoral ring and comes out through the saphenous opening. So the swelling of femoral hernia will be 4 centimeter below and lateral to the pubic tubercle, right? So the second picture is showing you how the hernia is occurring. Femoral ring, that's the saphenous opening. So bowel enters, comes out, and that's a picture showing you the clinical picture. So that's how the femoral hernia presents. So inguinal hernia will be above the inguinal ligament, above and lateral to the pubic tubercle, whereas femoral hernia will be below and lateral to the pubic tubercle. Now the repairs of femoral hernia, both laparoscopic and open repairs, as I have already told you, TEP and TAPP takes care of femoral hernia also. Open, there are 3 techniques depending on what incision we use, because femoral ring is right at the margin between the abdomen and the thigh, that is under the inguinal ligament. So we can enter above the inguinal ligament, through it, just below it, and way below it. So based on that we have multiple techniques. So suprainguinal or high repair, if we go above the inguinal ligament, that's called McEvadis repair, right? It's more complex, not routinely used. It's mainly reserved for suspected strangulation cases of femoral hernia. And remember, femoral hernia is, amongst all hernias, femoral hernia is the most common hernia to get strangulated. Then low is infrainguinal repair, below the inguinal ligament, Lockwood's repair. That's one of the most commonly used open techniques, best, simplest, easy to do. And third is through the, just below the inguinal ligament, that is called transinguinal repair, that is Lothaison's transinguinal repair. So we are done with the inguinal and the femoral hernia. Now we'll move to ventral hernias, that is epigastric or paraumbilical. They are technically same along the linea alba, right? And the repair is more or less same for both of them. So either if the defect is very small, like 1.5 centimeter, we can simply just close the defect, simple suturing, nothing great. Meo's repair, very important. Here we do, it's a kind of herniorrhaphy. We are not putting any external mesh. So that's double breasting of rectus sheath, like in this picture you can see. So that's a rectus sheath with the defect. So double breasting again, one over the other. So that gives additional strength. Now mesh repair, open or lap mesh repair here is known as IPOM, that is intraperitoneal onlay mesh. Intraperitoneal onlay mesh, IPOM, is a technique of laparoscopic mesh repair of ventral hernias. So it's same for epigastric, umbilical, paraumbilical, and also the incisional hernias. Open techniques, outside the defect we call it onlay or overlay repair. If we place the mesh under the defect, which is better, ideally inlay or underlay repair. I'll explain this in detail little later. Now congenital umbilical hernia, again very important, right? Initial few years, because the defect here is umbilical ring, right? That's a natural anatomical space. In preterm babies it remains open at birth, so umbilical hernia occurs. But in initial 2-3 years of life, as the child grows, gradually the umbilical ring might close spontaneously. So don't rush to operate umbilical hernia at birth, right? So majority, more than 95%, will close within 1 to 2 years of life. So just observe, right? Only if they get obstructed, strangulated, then go for repair. Otherwise, children less than 3 years, congenital umbilical hernia, we do not repair. Wait and watch. But if it is inguinal, it has to be operated as early as possible, elective. Okay, now the mesh positions, again very important, right? Onlay, as I told you, outside the defect, also known as overlay. Inlay is in the defect or interposition. I'll show you the pictures. Underlay is under the defect. Underlay or sublay. There can be 3 varieties of underlay. So if you just know the anterior rectus sheath, then you have rectus muscle, then we have posterior rectus sheath, then we have peritoneum, right? So One variety is retromuscular. Retromuscular means we like place between the rectus muscle and the posterior rectus sheath. We place our mesh here. This is this variety. Retromuscular means behind the rectus muscle, between the rectus and the posterior rectus sheath. Then other variety is pre-peritoneal. Pre means now between here, between the posterior rectus sheath and the peritoneum, just in front of the peritoneum, right? And third is intraperitoneal. Laparoscopically, as I told you, we can place the mesh intraperitoneally also. This is called IPOM, that is intraperitoneal onlay meshing. So this is the picture showing you different positions. So if you place outside the rectus muscle, this is onlay. If you place in the defect, this is inlay or interposition. Sublay retromuscular, that is behind the rectus and between the posterior rectus sheath. Then sublay pre-peritoneal, that is between the peritoneum and the posterior rectus sheath. And sublay intraperitoneal, that is IPOM, which is inside the peritoneum, right? That's the IPOM. View from inside, we are placing the mesh, that's a defect, and we are covering it with the mesh from inside. That's a laparoscopic IPOM, right? As you can see here, so the defect is behind it, we have completely covered it with the mesh. Now last is incisional hernia. Now incisional hernia, again when we talk about repairs, simple closure for less than 2 centimeter defects, suture repairs, the older techniques. Suppose you are working at some peripheral center, you don't have a mesh available, so you must know about it. Different names: keel repair, Dan repair, lattice repairs. They are the traditional heavy suture repairs. Now muscle pedicle flap repairs, just for the theoretical purposes, we can use tensor fasciae lata or rectus femoris muscle flaps, pedicle flaps. Best is, like before we have been discussing for other hernias, mesh repairs. The technique is same, onlay, inlay or sublay, like we have just discussed. Just the few names like we saw in the previous slide. Keel operation. Keel operation, it's an anatomical repair, it's a herniorrhaphy. We are not using mesh, we are just using the suture. Thick suture, non-absorbable suture. Old technique used for giant hernias, but now it's not used because mesh is easily available. In this, hernial sac is not opened, rather we invert the hernial sac back into the peritoneal cavity, and then with the non-absorbable suture we close it like the keel. So that's a hernial sac. So we push it from both sides, invert it, and then we close it like a keel. Now shoelace Dan. Shoelace Dan is, or lattice repair, is again a similar repair, anatomical suture repair. In this, using a thick non-absorbable suture, we recreate a new linea alba, we reconstruct, bringing both sides oblique muscles closer to each other and closing the defect in this fashion, as you can see. So that's the both sides oblique muscles, the rectus sheath. So that's a defect. So in a shoelace manner, we close the defect in multiple layers, recreating, reconstructing a new linea alba and closing the defect completely, right? So that's another picture showing you the lattice repair. Thank you.